Hi, my name is Louise Wen, and I am a senior anesthesia resident at Stanford University Hospital. I'm here to talk about contaminated sharps injuries in anesthesia residents. If you had asked me at the beginning of residency the risk of getting a contaminated sharps injury, I would have guessed maybe 10%. When I had a dirty needle stick injury at the end of my CA1 year, I became interested in learning more about the topic. Our occupational health department reports that anesthesia residents have the highest incidence of contaminated sharps injuries among all house staff specialties at our hospital. Halfway through my CA2 year, I sent out a survey study to all 27 CA2s in my class. Within 72 hours of survey launch, we had a 100% response rate. 67% of individuals reported having a contaminated sharps exposure, and 9 individuals had multiple contaminated sharps exposures. 3 individuals had exposures to patients who were HIV positive and completed a month of antiretroviral prophylactic therapy, and 2 individuals had exposures to patients known to have hepatitis C. The only standardized sharp safety training was a mandatory PowerPoint presentation that was developed by the Office of Graduate Medical Education. In our survey, only 3 individuals reported even remembering receiving such training. Our survey identified 3 areas of improvement: safety devices, systems improvement, and education. The first area of improvement involves the universal utilization of sharps devices that have a safety mechanism engineered into the function of the device. This would apply for hypodermic needles, IV needles, and arterial line needles. The second area of improvement involves the use of ancillary sharps safety equipment. They include a dedicated Mayo stand for anesthesia procedures, sharps containers with amply wide lids, and sharps-only neutral zones to avoid hand-to-hand transfer of sharps devices. The third area relates to education. Our plan is to lead a hands-on workshop on sharp safety training for our incoming CA1s during orientation. This will familiarize our new residents to the sharps procedural equipment they will use throughout residency. It will also provide strategies on protecting themselves from injury, such as avoiding sharps during blood transfers. We also plan to teach our residents how to improvise contaminated sharps holders, here using Rest-On foam for the arterial line needle, or using the skin cleansing sponge in the spinal kit. Our plan is to repeat the survey study in a year and a half to evaluate the effects of these interventions on our new CA1s.